Hodson, and tonight I will be standing in for Susan Cole, who unfortunately can't be with us tonight. So Susan, if you're watching, you shouldn't be, you should be resting, but we all hope you get well soon. Tonight's edition, we're going to be talking about people living with HIV who've been lost to follow-up. Now, the UK is renowned for being one of the leading countries in the world in terms of hitting targets for HIV diagnosis, people on care, and people who are virally suppressed at undetectable levels. And when people are undetectable, the virus is untransmittable, U equals U. So obviously getting people virally suppressed is incredibly important in terms of our efforts to end HIV infections in this country. Now, we've been saying for a while that we're doing really well. In fact, we hit the UNAIDS 95 targets a couple of years back. That's 95% of all people living with HIV diagnosed, 95% of those on treatment, and 95% of those virally suppressed. In fact, the figures that we claim to have reached are 95, 99 and 98 for those three measures. However, new data has emerged which suggests that the number of people who started care but have actually fallen out of care is higher than perhaps we had realised. And so tonight I've got a brilliant panel of guests who are going to look at the reasons why this may be the case, what the true picture is, who's most affected, and what actions we can take to support people and ensure that as many people are in care and virally suppressed and healthy as possible. So let me introduce our incredible lineup of guests. First of all, I'm going to introduce Dr. Alison Brown. Dr. Alison Brown is one of the world's leading HIV epidemiologists. She'll laugh at me for saying that. And she works for the UK Health Security Agency. Next, I have Estelle Duncan. Estelle is an HIV advocate and activist. She is one of the leading mentor mothers for the 4M project, and you're also the founder and director of Positive Child UK.
Yes, thank you.
On my right, I have Dr. Kate Childs of King's College Hospital. Kate has been very actively trying to re-engage patients back into HIV care. And finally, last but definitely not least, I have Kuba Krzyzynski. Kuba is the peer mentor leader for the diversity and equality charity Metro. Kuba is a migrant and he's a gay man living openly with HIV.
Thank you.
Welcome all. We're going to have a fantastic discussion, but really, first of all, I'd love to set the scene. Alison, so how many people do we think have actually been lost to care?
Thanks, Matthew. You're right. We're very fortunate in the UK that we have such a fantastic health service, and we know that 99% of people who are living with diagnosed HIV infection are treated, and 98% of those are people who are virally suppressed. But there is also this hidden population, and in the UK we are able to track how many people are seen for care each year, and we estimate about 4,500 people weren't seen for care for at least 15 months in the most recent year. That's of concern to us. It's a concern to us for two reasons. Firstly, these individuals are obviously not able to access treatment, and as you know, people living with HIV need treatment to live long, healthy lives, prolonged lives into 70s and beyond, and also it means that if you're on treatment and you take your treatment to have an undetectable viral load, you can't pass HIV on. So it's particularly important that we are doing all we can to support people to get back into care. We're also concerned because this proportion of people, this number of people who are not retained in care is increasing. So prior to COVID, we had about 2,500 people out of about 100,000 living with HIV who are not retained in care. Post-COVID, that number doubled. And now we have seen some improvement, but we still have 75% more people who are not retained in care than we did prior to the COVID pandemic. And that for us is of particular concern.
So that means that we've actually got more people who have been lost to treatment and care than we have people who are undiagnosed.
It's pretty much equivalent amounts at the moment, and there's a lot of emphasis, and quite rightly so, in getting people to come forward to have an HIV test, to know your status, to get onto treatment and care. But equally important is, again, this hidden population who are extremely diverse, and it's much more challenging, I think, to make sure that we're reaching out to these individuals and giving them the support they need to get back into care. So I would say the numbers are actually pretty much even at the moment, and it shows we need to have as much emphasis on people lost to care as we do in getting people who are undiagnosed tested.
And Kate, now, we've been talking about having an emphasis on getting people back into care, and actually this has been a project that you've been leading on at King's College Hospital. So what have you been doing to get people who've been lost to care back into care?
Well, it was a few years ago that myself and a group of colleagues from South East London sort of made the observation that we had a fair number of patients who were inpatients on the ward with HIV infection and AIDS-related illnesses who experienced really poor outcomes. So died or ended up living in nursing homes, left permanently disabled, and these are people in their kind of 40s or 50s and not very old people. And we thought, and many of those patients were people who'd been previously diagnosed and then lost to care. And so essentially we approached the Elton John AIDS Foundation to try and secure some funding for a dedicated project in South East London. And we just systematically across 3 hospitals, so King's, Guy's and St Thomas's and Lewisham Hospital, we looked at all patients who we hadn't seen for at least 1 year, but going back quite a long way, going back as far as kind of 2012, and people we saw a while ago but haven't seen since. And then we systematically tried to contact all those people and see where they were. And in fact, we got a lot of invaluable help from the UK Health Security Agency, because we sent that list of people who we hadn't seen to the UK Health Security Agency, and they were able to tell us which people had been seen somewhere. So we could kind of stop worrying about those people because they'd been seen somewhere else in Britain, for example.
So they'd moved
area or whatever, yeah, exactly. Which left us with a list of people who hadn't been seen anywhere, as far as we were aware, and we then systematically tried to contact them. And the money we got was really for that resource of having a worker to systematically contact those people by phone, text, etc. And essentially, over about an 18-month period, we managed to re-engage 150 people back into care across South East London. And it was about 75% people of black ethnicity. It was more than half female patients. And of the people who came back, half of them had a CD4 count of less than 350. A third had a CD4 count of less than 200. Some of them really low. And so that was the project. And that since then we've carried on that work.
So, I mean, more than half were women, and actually in the UK, more people living with HIV are men than are women. So it means that women are very disproportionately more likely to fall out of care. Now, you work with lots of women who live with HIV. I mean, does this chime with your experience?
I have experienced women lost to care. We had a date night with THT, which was very open discussion, and women were talking about situation and issues that are surrounding them and their peers. And this came up a lot. There's people have lost to care because of faith. Faith comes up a lot.
Oh, okay.
And there is people who have gone to faith leaders, have traveled out of the country and have gone and they have been prayed for, and they've stayed there maybe for some time, and they will come back and they go and re-engage in a testing to check if they are negative.
Because they believe that
yes, because they believe they've gone
really
there, they've paid some money to this pastor or bishop somewhere, and sometimes they are very famous, these leaders. So people are engaging in that kind of religious leadership and going to pay money to get healed, and then they come back and re-engage again to get a test, and it still comes up positive.
So if you are talking to someone, you're talking to a woman and she says to you, oh, I've decided that I'm not taking my HIV treatment anymore because I believe that if I have faith and if I pray and if I do what my religious leader tells me to do, that will cure me. What do you say to someone in that situation?
You know, at the end of the day, it's their own decision. You know, you cannot change their decision. But I always encourage them and giving them the messaging of U is equals to you. How important the messaging of taking your medication, being undetectable, getting your viral load to zero is very, very crucial for living a long, healthy life. So I really empower women to continue taking their treatment. It can be challenging sometimes because they don't believe. And they will cut off the phone. Sometimes I'll call them, they'll just put the phone down. But I continue engaging them and just giving them information and giving them an informed choice. Let them make an informed choice and giving them examples of how healthy people are living. People are having children and they're living a healthy life.
I think it's informed choice is the absolute mantra.
Yes,
It's always can't impose health upon someone. We work with people. Now, are migrant communities particularly affected?
Yeah, I mean, yes, they are one of the groups that are affected for sure. Broadly speaking, we found most of the people who were re-engaged back into care fall into several broad categories. And it will be people who are really affected by stigma, for example, people which often will affect migrant communities, people, women in particular actually, who have what we would call competing needs, meaning they're so poor or they have immigration issues or they have terrible housing or they're working 2 jobs or they have loads of kids that they look for after all by themselves, that they're just so busy they can't afford to prioritise their own health. So that's a massive group of patients, kind of competing needs. Then patients affected by drug and alcohol addiction, patients with serious mental health problems, and those groups I would say account for almost everybody. So there's several kind of groups who we see again and again.
Now, Kuba, you work with groups of gay men living with HIV?
Yes.
And so, I mean, Kate has just talked about issues around migration status being an issue, but also issues around drug use and issues around stigma. Do you encounter that?
Yes, so my main focus in my workplace is working with migrants and especially asylum seekers and refugees living with HIV. So I decided I want to open a group for them, the peer support group for gay men, migrants living with HIV in London. And we've seen lots of people come in, and then obviously I speak with them every day, and they, even if they on the treatment at the moment, but they in the very high risk of being lost in care. So when I discuss it with them, the HIV is the last thing on their mind, of their concern, because they came here to claim the asylum, they live in some home office accommodation, which is usually horrible state. They get something about £7 per week, I think, or something like that from the government to survive. So they come to me and they tell me, very soon we're not gonna go to the clinic because the clinic is far away and we all know how expensive transport is in London. So they said they wanna spend this money for their food rather than go to the clinic and get their medication. So we try to, what I do mostly, we do speak with Home Office, but you know, it's not obviously always working. We write letters because Home Office try to often send those people away from London. So they have accommodation for them, but they say you have to move from London, you have to live in the countryside sometimes, where there's no clinic for HIV. So again, they will, if they send them to the small town or a village where there's no HIV care, and the other thing is there's no peer support, so they build that community in London, so we try to keep them here. So yeah, I see a lot of that. That's my main work there.
The government is pursuing a policy quite clearly of saying that refugees and asylum seekers are not particularly welcome here. I mean, it's a hostile environment. What impact do you think that has on people accessing care if they're living with HIV?
Yeah, so that is, it's true exactly what you say, and I think the other thing is, especially if English is not your first language, and most of my clients, English is not their first language, the one who don't speak much English, they usually resistant to go to the clinic because they come to us and they tell us, what is the point for me to go to this doctor if I'm not going to understand her or him, you know? So what we also try to do in the charity where I work for, we try to have a group of volunteers and workers who speak at least they're bilingual. So then we can help those people who speak all sorts of languages. And then we try to call the clinic or we go with them sometimes. If we know there is another clinic where someone speaks the same language like them, we try to change the clinic for them. And they're usually very happy about that. They want to do that because they're ready to speak Portuguese, Polish, or Cantonese, you know, for example, to the doctor. But yeah, there's lots of barriers. The other thing is that they come to us, they tell us they're scared to go to the hospital or HIV clinic or A&E because they think they're gonna call Home Office. If they're illegally here, they think they're gonna be deported. So many people also I work with, they stopped going to the HIV clinic because they were scared of the prosecution of Home Office, and especially in current government situation, like you mentioned, people are sent away. They really want to avoid that.
I mean, it's something which has been kind of used kind of in political terms, is the number of people who live with HIV who come to the UK, but actually as a proportion of people who come to the UK, the number of people who live with HIV is lower than in the kind of general population of the globe. And so this idea of health tourism there's no real evidence that that's the case, but it's a real problem, of course, if people aren't accessing care, because that will mean their health is threatened, and also means that they will retain the ability to pass on the virus during sex. Now, Kate, you said something which I thought was really interesting. You said often it's not just about HIV care, and I think that's something which we who work in HIV, or me who works in HIV, and it's like, I'm always thinking about HIV, and like that's the most important thing. But of course, actually, if someone's living in poverty, then actually their own health, their own HIV care, may not be taking priority over feeding their children, for example.
Yes.
I mean, Estelle, is that something that you hear from the women you work with?
Yes, and the same, we don't have a peer support group, but we have a forum network WhatsApp group, and we've been having webinars. And in our WhatsApp group, we have about 45 women. And in the last month, we've had about 20 women who have joined, and they're all migrant women. And as you say, the same stories. There's a mother who sent me a message a few days ago. She doesn't have milk for the baby. So it's around the network. I had to send a message around to the local networks in Croydon or locally where she lived, because she was really desperate. And there's also other mothers who are homeless. I've been moved to this home, I'm being moved to the other one, I'm moving to the other place. I forgot my medication in the other place. So at Forum Network, we try our best to send them mentees. We have mentors, mother mentors, we network together. So if there's a mother mentor in Croydon who can engage with this mother, go and visit her, just talk to her, help her, or engage with her in different ways. And if there's other organizations also who can support at that moment of maybe with baby milk or nappies at that moment, we do that. So we do have organizations that are also working with us in terms of helping these migrant community moms with essentials for the baby, which is very, very important.
So, Kate, you talked about stigma, and I think we always talk about stigma as actually challenging stigma is absolutely essential to ending the epidemic, and we see it in that it creates barriers to HIV testing, but also, as we're now talking about, it's creating barriers to people staying in care. From each of you, what's the one thing that you would do to tackle HIV stigma? I'm going to start with you, Alison. Can't put you on the spot.
What a difficult question. I mean, as you say, stigma is all pervading. We know that it's still extremely prevalent in people living with HIV, and also in the general population as well, and also to a certain extent in the healthcare service. And we know from our survey Positive Voices that stigma is felt in lots of different ways. We have a self-stigma where you're feeling yourself, if you're living with HIV, that you potentially feel that you're still living with a virus and don't feel clean. There's also stigma you receive from your friends and your family and the healthcare workers. In terms of practicalities, there are some easy wins. So I'd say the first thing to do, we can do easily, is training in the healthcare service, so that people are aware of how HIV has changed enormously over the past 40 years now, in particular getting the message out that U equals U. We still don't know, there's not great awareness of that amongst healthcare professionals. In terms of stigma, I think also peer support is crucial. It's not easy to get people into care. It's far more than just having, and we still don't have the money for this even, nurses ringing around saying, please come back into clinic. You need to do something more than that. So I think the peer support, so people get the opportunity to talk to other people living with HIV, making sure it's culturally competent as well, it would be a first step. That's no means a cure, but that's, I would say, the obvious initial things to do.
I would be incredibly remiss in my duties right now if I didn't mention the fact that National AIDS Trust and NAM and Positively UK are currently collaborating on a project which is going to support people who work in healthcare and in other organisations to become HIV confident, so that we can be assured that they're going to treat any of their clients or any of their employees who live with HIV in a way which is competent and considerate, and are fully aware of what it means to live with HIV now. So I'm glad you prompted me to say that in one of our projects. Kuba, what are your thoughts about how we could tackle stigma to help support people to stay in care?
I would say what you said, Alison, the same thing, like, the self-stigma. And obviously, I will talking again about the migrant community. They bring so much stigma with them, wherever they came from. And I work with people with probably all the religion, from back home, from their own country. I would say, obviously here, if you was brought up here, it would be much easier probably to get used to it, the fact that you live with HIV. But when you come in for very Christian family, very Muslim family or Jewish, it's completely different story. So what you said is true. You see that we put people together in the room of peer support, and if they have someone from the same background or the same religion or the same country, and they can speak the same language in the room, that I could see they change. They used to come sit in the corner. Some of them didn't speak much at all, and now they really open up. So we see that change. So peer support definitely for the self-stigma, yeah.
Estelle, I'm going to vary the question a little bit for you, just because you were talking about faith earlier on. Is there a role that faith communities can play in tackling HIV stigma?
I think it's about us to engage with the faith leaders. The faith leaders are very, very powerful, and they command lots of community groups until we sit down with them and they become part of us, so that we can engage them, and so they can sit down on the table and have the knowledge and education, more education, not only to the faith leaders. I would like those tombstones, advertisements, to change to U is equals U messaging. Mothers having babies, mothers breastfeeding. Those messages need to change. People need to see how people are living with HIV today. I think that's lacking.
And Kate, you speak to a lot of people who are coming back into care because of your hard work and efforts. So, I mean, what reflections do you have from that about stigma and how it has played into that?
I mean,
position?
It's such a massive problem. I'd say, whatever anybody's reason for not coming, perhaps because they are depressed, perhaps because they have competing needs, perhaps they have immigration problems, there's like a layer of stigma that runs through it all, like a stick of rock. Do you know what I mean? Like, it kind of is part of almost every person's reason for not engaging in care. And it can be things like people are scared to enter the clinic because everyone in the local area knows that clinic's the HIV clinic and people will see you going in. You can bump into somebody you know in the waiting room, and I've had at least 2 people who have just bumped into somebody they knew in our waiting room, and almost as a preemptive shot, that person has then gone around and told everybody in the local community. Somebody got chucked out of their accommodation. Like, it's a real... People are trying to conceal their diagnosis because it will have a real impact on their lives. They will lose friends, they will be ostracised, they will be thrown out of their accommodation. People are terrified about the impact on their children if the community realise they have HIV infection. So it's really pervasive, and it's a really sinister thing. And also often people experience stigma even from their own partners. So we quite often see a pattern where the one partner is, saying, you haven't got HIV, it's not true, you don't need treatment, don't go to clinic, and actively discouraging their partner from going. And in those situations, if the relationship then comes to an end, then of course we find that person then does very well and comes in and engages perfectly happily. So it just pops up everywhere, and it's something we really need to try and tackle, but it's easier said than done.
Yeah. So the question I was going to ask, which was following up from that, was you talked about confidentiality and how actually the kind of fear of being discovered, of being exposed to someone living with HIV plays such a huge part in many people's decision to disengage from care. Now, one of the solutions that has been mooted around kind of getting people back into care is to link HIV patient records with general practice patient records. I mean, do you think that's a good thing or a bad thing, considering there's these very real concerns about confidentiality?
I think we have to respect people's confidentiality, obviously, but I think we need to educate the rest of the medical community. We need to stop HIV being some sort of special case and different to everything else. It's one of the most treatable illnesses we have. If you take the medication, which is often 1 pill once a day, very few side effects, your outcomes will be no different to anybody else. There aren't that many illnesses which have got such great treatments available. And I have to say, as part of our kind of re-engagement work, the whole secrecy and cloak and dagger, and you can't tell the GP, you can't phone the GP, even if the GP is seeing that person every day for their high blood pressure, and that could be a valuable opportunity to bring the person back into care. I think generally speaking, too much secrecy and perpetuates the stigma in a way. So whilst we need to be obviously incredibly respectful and careful, we also just need to stop treating HIV differently to everything else, because sometimes other healthcare professionals are a really great ally in bringing people back into care.
Kuba, what would be your thoughts about linking people's HIV health records with their general care records?
So I can speak from my own experience, probably that's best. So when I was diagnosed, that was 2016, so it's 7 years ago now, I was advised by my HIV doctor that, you know, we can't tell you to do it, but we advise you would tell your GP about your status. And I never had a problem with that, so very quickly, I think probably after a month, or whenever I was first time in my GP, I did tell them. But my role now in my workplace is that I say that to my clients, which is very difficult again, because they don't want to, some of them, they don't have a GP, they don't go to the GP because they think they're not allowed to have a GP in this country, or they have to pay for medication if they're refugees. So the work is mostly focused on that we do encourage them to speak to the GP and tell them, or if they don't have a GP, I go with them or I sign them for the GP. And then we try to tell them that it's very important that the GP knows about the HIV because of the certain medication they're gonna prescribe and whatever. So that's what we do.
It can be a real problem. I remember, you know, personally, and this was quite a while ago to be fair, I'd done something, I twisted my ankle, and I went to see my GP, and I said, I just mentioned, oh, I'm living with HIV, and I saw him write down, problem, he has HIV. And I'm like, that's my ankle, it's really nothing to do with my HIV at all. Estelle, what's your opinion on linking?
I think, as Dr. said, education, more education, more education. And until we as peer mentors need to encourage the mothers to talk about their HIV to the GP, because some of these mothers want to breastfeed. They might get sick on odd hours. They have children, and treatment interactions also is very, very important for them to be aware that sometimes holding back all the information from the GP, you might need some more support from the GP than you need, because if you're not talking about your HIV, you might miss out on some help. And some GPs are actually very HIV friendly and are aware about the best care that they can give you. So I do encourage, you know, but it's still their own choice to decide. But I always say it's a bonus, it's a plus opening up to your GP. Your GP is not going to come around and talk about it with neighbors and stuff like that. They're aware about confidentiality. So I do encourage them to talk about it with GP.
You're a founder of Positive Child UK.
Yes, it is.
Now I think we need to acknowledge, of course, that actually it's relatively rare now for children in the UK to be born with HIV, because our testing is good and because the mother is on treatment, and so
and they are breastfeeding,
and
as
they're
well.
breastfeeding, and they can breastfeed, so this is fairly rare. But it's also the case that young people quite often fall out of care or stop taking their treatment.
That's very true.
Is that something you've encountered?
Yes, at Positive Child, it was founded in 1998. There was quite a number of women who had children who are HIV positive, and they felt left out, and they just created their own network to talk about their own specific issues about what they were going on at that time. Until now, we didn't have funding to continue till today, but we still have a link and we still communicate. And there are children that have been lost to care, one being drugs, also prison, and also disclosure. I have an incident where a mother didn't disclose to the son until he was much older, and it became really ugly. There was fight, and the son became mentally ill, and the situation got really, really bad. So there is quite a few number of these young people who are probably lost to care. And for example, I know one child who lost to care due to he couldn't move around, because in his area there's gang-related issues. You know, the situation in London, there's gangs, the young people between age of 14 to around 18. They are quite isolated. They stay at home a lot. There's fear of the streets. So this child did not go to the clinic. He had transitioned to become an adult, and he did stop going to the clinic. His viral went to 3 million. His CD4 count went to nearly to 20. He had completely very, very unwell. So me working with this family, the message of you is equals to you, changed his life. I went and sat down with him and I was encouraging him, saying, this is the message. You is equals to you. You'll have children, you know, you have a girlfriend, because he had given up. He had given up completely.
I mean, I hear these stories about adolescents and teenagers, and I think back to when I was a teenager, and I can assure you, I was a nightmare. And I was so transgressive and disruptive. And I just find it really easy to understand how being a teenager and your hormones are raging, you hate
so
the world,
difficult.
your parents in particular, and if you've always been told this is what you have to do,
So yeah,
you want to do the opposite.
yes, definitely.
So what do we say to young people?
I think the message is we still continue to, this message you is equals to you, change this child's life. I still talk to this child. This child viral load has gone down to 30,000 from 3 million. He's doing really well. He's put on weight. The hair is growing. So that messaging is so crucial. And they understand it. That if they take their medication on time, they can have babies. You know, I show them information from NAM and all the other platforms.
The best
And it's
provider
really,
of
really a
information.
good information. But also, I would like to have, if they could have, like, I know there's peer navigators and mother mentors, transition navigators somehow. That because these children from maybe being in a pediatric clinic move to adult clinic. I don't know how it's done, but they move to this clinic and then they have become adults and then the hormones are raising. If they could have like buddies who can just guide them a bit there in terms of their treatment, their care, and just hold their hand a bit. Because sometimes they don't want to see mom. Mom is the last person they want to see.
I mean, I'm old enough, of course, that I remember very well, far too well, the days before we had effective HIV treatment, and I remember seeing friends of mine get ill and dying. Do you think that perhaps for younger people, maybe not having that kind of visual memory of what it looks like? I think, you know, death is always very hard to contemplate. One's own death is, and especially when one is young. But there's some recent data which has just been presented at the IAS conference, the International AIDS Society conference in Brisbane, which was looking at people who had fallen out of care. It was a South African study, and it said that people who had fallen out of care for a period of 6 months or longer and had then re-engaged in care, but their likelihood of death in this cohort was 2 to 3 times higher than for those who had stayed in care. I mean, you know, that's extraordinarily high, considering these are people who actually did come back into care.
But I have to say, I mean, that rings true. We have had a number of people come back and re-engage, and then shortly afterwards develop an AIDS-defining illness, Kaposi's sarcoma, quite a few cases of other malignancies. So I'm not that surprised, and especially often if maybe people had like a period of slightly reduced adherence even before they then disengage, or some people have been disengaged for a long period of time. So there's no question that it affects your outcomes, which is a kind of medical word, but it means you get really ill, and and sometimes die or are left disabled. But I do think this thing about it's a good thing that of course HIV has been such a great success story, but I think a lot of people, they don't feel ill, and even though people have been nagging them for years, oh, you must take your treatment, they still feel fine, and it acts as a positive reinforcement. But of course then when they do become ill, they become really ill, and then they're very upset and regretful. So I think that's where peer mentorship plays such a role, and also really good education to say, look, it's really important to take your medication and remain healthy, because the other side of it, people become very, very unwell. So I do think we need to educate people that it's a great news story provided that you take your medication. If you don't, unfortunately, the outcome is very, very different.
So what are the actions that healthcare providers can take now? I mean, if we have healthcare providers watching, what are the actions that healthcare providers should be taking now when they're dealing with people living with HIV, to make it as easy as possible for that person to stay in care. Kuba, do you have a thought?
Can you ask the question again?
What should people be doing to ensure that people stay in care? What should healthcare providers, what should the government be doing?
I think
what needs to change?
Yes. So what we did in South London, and I work closely with Kate, and in her hospital, which is King's College, we place a peer mentor in the clinic, and that helped because we've seen people who were detectable with detectable viral load, and then how many percentage of them become undetectable after a few months, let's say, of working with the peer mentor. And I'm really glad to see that actually, I can't speak so much about North London because I don't operate there, but we mostly based in Southeast, that at the moment we have partnership with 8 hospitals. Before we had 3, now we have 8, all in South and East London, and we place 1 peer mentor in each of those clinics. And I think that's the key. So if someone will be newly diagnosed, they should be offered a peer mentor, someone who lives with HIV definitely, straight away, not later in the journey, but straight away. So that's mean from the beginning they will be told how important it is to be on medication. Obviously, I can speak because I live with HIV. It's completely different if you go to your doctor, and your doctor, they are amazing and they do the great job, and the HIV nurses amazing. But the majority of them, they HIV negative. So if I go, and I know my clients are the same, and a doctor will tell you, you have to take your medication. But then you might think, what do you know? How do I feel?
Yeah.
You know that from the medical point of view that you want to keep me alive, and it's great. But what's going through people's life, and like we mentioned, homelessness, mental health, 1,000 other things than HIV, then they think usually people, that pill, this is the last of my problem at the moment. I have to deal with my where I'm going to sleep tonight, I might be on the streets. So, but if you have a person who live with HIV who talk to you, it's completely different outcome. I have that when I call someone, right? So the nurses or the doctors will signpost someone to me, and they say, can you contact this person? When I call this person, newly diagnosed, they normally don't want to talk to me. They say, we don't know who are you, why are you calling here? The moment I tell them on that, and I know I have to do it quick, otherwise they will put their phone down. I say to them, I live with HIV as well. They say, okay. So now we can talk. So, and they straight away want to talk to me because probably I'm the first person they know that talk to them who is in the same situation. So that always helps.
I mean, there's a lot of support that comes from the voluntary sector, and a lot of people give up a lot of their time. But these programs of getting people back into care cost money. You said that the work that you were doing was funded not by the government, by charity. Is there enough money to get people back into care? Have we got the funds sufficient to solve this problem?
I mean, my feeling is people who are hospitalised with AIDS-defining illnesses cost the NHS a lot of money. I mean, the human cost is actually far more important, but if we're literally just going to talk about the money, it's very, very expensive. Some colleagues did some work and found that your average inpatient stay with HIV-related illness is £18,000. Okay, so if you have quite a few of them, then it adds up very, very quickly. So almost any investment we make that will reduce people developing AIDS-defining illnesses will be cost-saving. So I think that's an argument we need to make. In South East London, the work was initially funded by the Elton John AIDS Foundation, but we've been able to make the case that it should be funded by NHS England, and it's funded through the local, they call it the integrated care system, which is like the local way that money's dealt out essentially. So in South East London, we are funded to do that work. And I think we can also somewhat repurpose the money we already have. Most people living with HIV, of course, very stable, very well, pop in once every 6 months, then they're off to work, going on holiday, living a normal life. That group probably need less resources than this group who are so in a terrible situation for lots of reasons. So I think we need to maybe be a bit more light touch with people who are absolutely fine and don't need us so much onto this group who really need us. And even if it just means moving our funds, that's what we should be doing a bit of.
I mean, we've talked a lot about health, obviously, because obviously if people are out of care, then their health is imperiled and their lives are imperiled. But we also recognise the enormous impact that people who fall out of care have in terms of our ability to prevent new infections. Alison, when we talked about the 90-90-90 or the 95-95-95 targets, and those targets are set actually more about prevention. I mean, obviously we want people to be in treatment because we want them to live long and healthy and fulfilling lives, but there is also the element of we want to end the epidemic. Are those 95 targets, are they still fit for purpose?
That's a very good question. I mean, as you say, I think it, as you say, that the first reason why they're there is to try and increase the number of people who are untreated and virally suppressed, because the primary purpose is to prevent deaths. Secondary purpose is to make sure people are living long and healthy, and then we also have this public health purpose to maximise the number of people who have undetectable levels of virus. U equals U, so you have the majority of the people living with HIV unable to pass HIV on through sex. I think it's been a particularly useful exercise internationally to have the 90-90-90 targets. That is for people who aren't aware. For 90% of all people living with HIV to be diagnosed, 90% of all people living with HIV who are diagnosed to be treated, and 90% of all of those who are treated to be virally suppressed. And that's useful because most countries can measure those metrics. So you can compare between countries and you can see where you need to put your efforts into, but they can be misleading. Firstly, because they mask the number of people who haven't met those targets. The percentages might be high. In the UK, we have 100,000 people living with HIV. 95% of people are diagnosed. That means we have about 4,500 to 5,000 people who are undiagnosed. And it's very easy to be complacent to say, we've met 95%, we don't need to do any more. Of course we do. But also, the 90-90 targets don't take into account people who've been talking about today who are not retained in care. And we're working to show how the 90-90 targets would look if we were also to include those individuals. And it does give a more accurate picture. So I really do think we need to start thinking about the numbers that sit behind those percentages, understand more about those populations. Kate spoke earlier about how people fall into 4 different categories, and I think we need to do more research in terms of what's the most effective way of getting those categories of people back in. People with a lot of difficulties in their own lives, they can't prioritise HIV, people with drug and alcohol misuse issues, all sorts of different reasons. Unfortunately, what we're doing at the moment is not scaled up enough, and it's short term, and there's a lot more we can be doing. I really think we need to focus on this area.
Just very quickly, I mean, we talk about UNAIDS targets and all of that, and our own discovery, if you like, that we're not doing as well as perhaps the surface data says. But that is also true, presumably, for other countries that report.
Yes, it is. I mean, we're lucky in the UK because we have a very good HIV surveillance system that we're able to track people living with HIV over time in terms of being able to see how quickly people start treatment, look at the long-term outcomes of people living with HIV. It's all confidentially kept for public health purposes, but other countries may not have that information, so that it's not possible to look at retention and care. This is not an issue unique to the UK, and in fact I think that due to the NHS we're probably doing a lot better than other countries, because the one barrier that we have overcome to a certain extent is the fact that treatment is free, care is free, and whilst you're quite correctly saying for migrants it's a big barrier in terms of whether it be reported to the Home Office, but the legislation in the UK is, regardless of your residency status, if you're an undocumented migrant, you are entitled for free testing, care and treatment. That might not be the belief of the people who are migrants, but theoretically that should not be a barrier, and that's a great thing.
It's really important that we continue to stress that.
Absolutely.
If you're a migrant in the country, you're entitled to free HIV testing and care.
Yes, absolutely. It's very. We need to make that message apparent, as well as the message of U equals U. But yes, it's not a problem unique to the UK, and I think we do need to start thinking of those not retained in care as forcefully and carefully as we think about those who are undiagnosed.
Now, I know in your project, you've literally got people ringing up, manning the phones, personing the phones, and calling people and trying to track them down. And it's a kind of a whole detective procedure. But are there other ways that we could encourage people to return to care?
Definitely. I mean, there's quite a few ideas that have come out of it. Some people have fallen out of care simply because they don't really know how to navigate the system. You know, as you were saying, maybe there's a language barrier, they don't really understand how the GP clinic thing works, they might not have a GP. So I think if we could just have one phone number that anybody could ring and just say, I've got HIV and I live in Birmingham, what shall I do now? And it's so easy, you know. In fact, you know, HIV clinics and community organisations were also networked together, that it would be really easy to organise an appointment for that person and even for somebody to go with them. But at the moment, people don't know where to get that help. So I just think one easy access phone number or website or email address or something would help people to navigate the system. So that's one really important thing. But I also think, you know, THT did a very successful campaign targeting people who were undiagnosed, you know, Give HIV the Finger. You know, if we're looking into similar numbers of patients who are out of care, we need some sort of campaign saying the door is open, treatment is available, welcome back, that sort of thing, something positive, because people also very, very much fear being told off if they've been out of care for a while. And so it's very important that all clinics have a very non-judgmental attitude and understand that the person's going through some difficult stuff. So there's lots of things that could be done on a national basis and on a clinic basis to improve the situation.
When I was discussing this show with Susan, when we thought she was going to be hosting it, not me, and I actually confessed to her, and I wasn't sure that I was going to do this in front of the cameras, but actually I dropped out of care. A few years after I was diagnosed, and I knew a lot about HIV beforehand, and then I missed an appointment. And I felt so guilty about missing that appointment. I was too embarrassed to call up the clinic and say, I'm really sorry, because I've wasted a doctor's time. And it was like my life was busy, not quite chaotic, but it was definitely busy at the time. And so there was never that moment where I felt able to ring up and just say, look, I just need to have another appointment, because I just knew that that conversation would be one which would trigger all sorts of feelings of guilt and shame within me. And so I dropped out of care for 18 months. And this was in the days before people were on treatment immediately. So I hadn't started treatment at that point. It was when you had to cross a certain threshold before you would start treatment. And of course, when I then did re-engage in care, I had already crossed that threshold, and so I had to start treatment immediately. I came back, and of course, you know, I look at all of the data around, you know, the health outcomes for people who start treatment at lower levels of CD4, and how some of those health outcomes are worse. And I'm like, well, that's me, because I felt ashamed and embarrassed about it. So I mean, non-judgmental services are crucial. Do you find that in your work, Kuba?
Yes, I was actually listening to what you said, and I wanted to say something else as what helped me navigate how to stay in care. So I was never a kind of person where I had too much problem of taking my medication. But, you know, I think all of us, whoever is positive, it's not a pleasant thing to see. For me, it was not to take the pill, it was to see them in the kitchen in the morning with breakfast. So that's the whole routine. I didn't like that routine. Waking up, opening the cupboard, eat your meal. The doctors always tell me you have to eat the meal with your pill. And I don't like breakfast, so I was always kind of angry eating that breakfast quickly before work and taking that pill.
Angry porridge.
Yes, exactly. And I know we didn't meet here today to talk about this, but when the injectables came, I thought this is my time to change that. And at the moment I'm taking injectables treatment every 2 months instead of the pill. And that psychologically, that helped me massively, because I don't have to see those pills, and I don't have them, and I don't see them, and I don't have to eat breakfast. Because with the injection, they told me you don't have to do that. So it's for me, that was kind of my way of navigating to stay probably in care, you know. Yeah.
Yeah, and I think that's a really important point, isn't it? Because sometimes it's just that ongoing psychological burden of knowing you have HIV, and sort of that reminder of it, and it can be very wearying. And I think it's fine if everything else in your life is fine. But for most people, you're going to go through periods when not everything else in your life is fine. You're going to be unemployed, or you're going to be heartbroken, or you're going to be homeless, or you're going to have challenges with drugs and alcohol, or you're just going to look at the general state of the world and want to throw your hands up in despair and cry. And when all of those things come along on top of living with HIV, it can be very hard to make those proactive steps to maintain your own health. What do you think is going to work in terms of supporting people?
I think what would work, and I thought about it before I came, is
We're expecting high things now.
yes, I think meaningful involvement from people living with HIV. At Forum Network, we have over 25 women who are trained mentors.
So, and the Forum Network is?
Forum Network is a project supporting mothers through their pregnancy journey and beyond, meaning the whole journey through when they have babies until they become grandmas. So we are the network. And we have mothers who are trained to be mentor mothers, and over 25 are trained, and we've got new mothers now, about 50 who have registered, who are going to have training. So money, I think it all comes back to money. The more peer navigators engaging at all levels of care, there could be a transitional peer buddy who could maybe mentor these children who are in transition. And also mother mentor transitioning, mothers who are being diagnosed during pregnancy, we engage with them. And in all levels, you are dealing with the migrant communities, having a peer navigator in that level also helps. So that is, for me, that would really, really work. Having us leading, yes, and engaging as meaningful involvement for people living with HIV.
Alison, is there more that you think that the UK Health Security Agency could be doing?
I think there's always more that we could be doing. I don't think there's one single solution. So it's doing lots of things in combination. So at UK Health Security Agency, we are committed, as Kate mentioned earlier, to sending information to clinics so people can more effectively identify people who are lost to follow-up, and not simply those who are simply being seen at another clinic. That's something practical that we're doing. We're also working with the opt-out emergency department testing, which is not only useful in finding people who are undiagnosed, but there's also a sizable number of people who are diagnosed with HIV who have not been seen in care, and we're following up those individuals to see if that's good enough to get back linked into care, or if it's not good enough because it hasn't got any of the follow-up peer support to see it through, etc. We're working with collaborators, UKHSA, looking at social prescribing to see if that helps people engage in care, and we also have a role in trying to monitor stigma and evaluate stigma in other settings, including healthcare workers as well. So there is more that we're doing, but I think the important thing to emphasise is that this really isn't a single solution. We need to do a lot of work in addressing stigma, a lot of work of U equals U. We know from research that gay men know much more about U equals U compared to heterosexual communities. I think it's something like about 80% of gay men have heard of U equals U compared to about 40% in Black African population. So a huge amount of work to do there. This is the general population, not people living with HIV, obviously. As well as tackling stigma, but we do need to bring people and the community with us. We do need to make sure that peer support's there, it's country competent, as well as and making sure that everything is out in the open and trust. I would not agree with data linkage to GPs. Absolutely, what happened with you is the ideal situation where you're encouraged to make that decision for yourself, and it's your decision to do that. There's a lot of range of things that we need to be doing, and they also need to be sustained. We can't just do an exercise for 1 year. This has to be a long-term commitment as part of our HIV prevention work.
I think that's so important, is that we need to make this commitment, and we're talking about potentially ending HIV in the UK, but we can only do that if there is a solid commitment, which means investment as well. We are out of time, can you believe it already? So that's all we've got time for, but I really want to thank all of the team at Disruptive, who've been marvellous as always. I want to thank this fantastic panel of guests, Dr. Alison Brown, Estelle, Kate, Kuba, thank you all so much for coming on the show. aidsmapLIVE will be returning in a few weeks' time, where we'll be bringing a special from the International AIDS Society conference in Brisbane. It won't actually be from Brisbane because that's a long way away and timings would be really tough. So we'll wait till people have returned to England and we'll do it then. And then it should be Susan hosting again. Susan, as I said, if you're watching, you shouldn't be, but we do all send our love to you and hope you get well soon. Thank you all very much.
Thank you.
Thank you.
Bye.
Thank you.